Perfect. Well, I'd like to thank everyone for zooming in to this afternoon's East End Libraries Health Talk in conjunction with Stony Brook University Hospital. We've been having these health talks for a couple of years. It's a different topic each month. I'd like to thank all of the East End libraries that participate for being able to share these events and for being active in this. Today we have Dr. Heidi Roppelt, who's going to talk about osteoporosis. She's a program director of internal medicine at Stony Brook University. And without further ado, I'd like to turn over today's health talk to the doctor.
Steve, this is Karen at Stony Brook Southampton. Do we have
Sorry.
the attendees admitted? I'm not seeing.
Yes, indeed. Yes, there's 18.
Okay. I'm Karen Wolfrat. I'm Director of Community Outreach at Stony Brook Southampton Hospital. And thank you to East Hampton Library and Steve for hosting our September program. And I just want to let you know that this is a continuing monthly series on the third Thursday of every month. And next, we will be doing a program on breast cancer on October 16th. And then our last program of 2025 will be on cardiology, high blood pressure on November 20th. So without further ado, I'm going to introduce Dr. Heidi Roppelt. She attended medical school at MCP Hahnemann University School of Medicine in Philadelphia. Her internship and residency were completed at Stony Brook University Medical Center, as was her fellowship in rheumatology. Dr. Roppelt is an associate professor of clinical medicine at Stony Brook University Medical School and is also the residency program director in internal medicine, helping to educate our resident physicians at Stony Brook Southampton Hospital, as well as director of scholarly activity. Dr. Roppelt sees patients at Meeting House Lane Medical Practice in West Hampton. She's board certified in internal medicine and rheumatology, and it's my pleasure to introduce her to you today.
Thank you, Karen, for that excellent introduction, and thank you to our host. Just give me a moment to, I'm just going to turn off my video because you don't need to see me while I'm telling you all the things that you need to know about osteoporosis. So welcome. Our topic today is regarding osteoporosis and living with osteoporosis. And I need to advance my slides, and I'm having a problem doing that. Okay, so the first thing that you need to know is that osteoporosis is a disease characterized by low bone mass and deterioration of bone structure that causes bone fragility and increases the risk of fracture. So nowhere in this definition is there actually a T-score associated with it. It really talks about, are your bones fragile or not? Although, and we'll talk about this in a few slides, what really, with regards to the screening process that we use a bone mineral density scan to determine whether or not your T-score or your bone density score falls into the range of osteoporosis. But your T-score does not have to meet criteria for falling into that range to say that you have osteoporosis. If you are breaking bones, even with a T-score that is above what we would expect or better than we would expect, but you're breaking bones, meaning you have, fragile bones, you qualify for osteoporosis. And we'll get into that in a little bit. So I love this slide because it really depicts the progression of osteoporosis across a family. So this is grandma, her daughter. And as you can see, they have significant kyphosis. They are stooped over due to vertebral fractures related to osteoporosis. Again, daughter's fractures are slightly less, so she's not quite as debilitated. And then her daughter does not have kyphosis. And our goal, at least from my perspective, is to prevent this person from developing this. So let me talk about a few myths when it comes to osteoporosis. First of all, one of the biggest myths is that osteoporosis is not serious enough for me to worry about. We think about osteoporosis as, yeah, okay, so my calcium content in my bones goes down, but it's not something that I need to worry about. Well, this is absolutely untrue. Osteoporosis is a progressive disease. It's irreversible, and it irreversibly weakens bones. Any movement or bump can cause a debilitating fracture, in particular compression fractures of the spine. Chronic pain and disability are the potential outcomes of this. So osteoporosis is not a painful disease. It's a silent disease. You will not have pain. You will not feel any symptoms until you break a bone. So most people, think, oh, I don't have osteoporosis because nothing hurts. That's not the definition of osteoporosis. You don't have to have pain to actually have the underlying condition. And until you break a bone, in which case, the horse is out of the barn, which is what we're trying to prevent, you won't feel any symptoms. Chronic pain and disability are potential outcomes, and hip fractures can cause death. There's a significant morbidity and mortality associated with having an osteoporotic fracture, especially a hip fracture. Myth number 2, I'm a healthy person. I do the right things. I'm not at risk. Myth number 3, I'm too young to worry about osteoporosis now. Actually, the time that we should be thinking about osteoporosis is in adolescence. That is the time when our adolescents really build their bone due to a healthy diet and calcium, vitamin D, where they make the most bone that they possibly can over the course of their life. So really the time that I should be giving this lecture is not to people over the age of 50, but it's really to people that are in their teens, to say, make sure that you have a healthy diet and calcium and vitamin D. Make sure that you do weight-bearing exercise. Make sure that you take care of your bone health so that you do not develop osteoporosis or as severe osteoporosis in your future. It is never too early to prevent osteoporosis, and bone, as we know, is a living, growing tissue that constantly rebuilds. As you're sitting in your seats right now, watching this, lecture, you have microcracks that are forming it's completely normal. And you have cells that come in and repair those microfractures. And what happens in osteoporosis is an imbalance between the bone degradation that occurs to take away the damage from a microfracture, for example, and then the cells that come in and repair that bone, so that you have an imbalance between the bone formation and the bone degradation. And that over the course of time leads to a net loss of bone or osteoporosis. Myth number 4, it's too late for me to do anything about osteoporosis. Completely not true. We have a number of excellent medications that are able to rebuild bone even in later years. So patients that are in their 60s, 70s, 80s, there are medications that are considered anabolic that actually rebuild new bone. And these are options for patients with more severe disease. So it's never too late to intervene on trying to correct this disease. So a little bit about the characteristics of bone. So as you know, bone functions as a mechanical scaffolding. It is basically the sort of the what upholds our body. It's a scaffolding that muscle and other tissue attaches to. It's also, however, a very dynamic metabolic reservoir for different metabolites such as calcium, phosphorus, magnesium, and sodium, and helps to maintain appropriate levels of calcium, phosphorus, magnesium, and sodium within our bodies. And those metabolites are useful in making sure that our muscles work properly so that our heart pumps properly. You have to have a certain amount of calcium, magnesium to pump your heart. So the number one function of bone at the expense of its own strength is to make sure that your blood levels stay stable no matter what with regards to calcium and phosphorus, magnesium, etc. So even at the expense of bone. So if your body needs to take away calcium from bone, it will do so in order to make sure that your heart muscle works fine and the rest of your muscles work fine. And as you can imagine, if you do not provide the appropriate amounts of calcium as nutrients, it's going to be taking it away from a different source that may be damaging or harmful. Bone also contains metabolically active tissue capable of adaptation to load and damage repair, which I alluded to before. And just a few words about bone remodeling or turnover. So bone remodeling describes the rate of bone formation and resorption. And I said that the primary problem in osteoporosis is that there's an imbalance in this bone formation and bone resorption process. So that in osteoporosis, you have an increase in resorption of the bone or taking away of the metabolites that we need or minerals that we need for good bone strength, and a decrease in the actual formation of new healthy bone. And because of this imbalance, bone becomes weak and potentially fragile. Bone formation is coupled to bone resorption. It's kind of like a scale. During growth or adolescence, turnover is high. So our teenagers are, very actively making bone, resorbing bone, and the peak bone mass is achieved at about the age of 30 years of age. So you really get to your top peak bone mass at the age of 30. So you can imagine if you didn't have a diet that was good in calcium, vitamin D, and all of the nutrients that we need to form appropriate bone, or if you had, a disorder with regards to anorexia, for example, that didn't allow you to have an appropriate nutrient intake, that this can harm the amount of ultimate or optimal bone formation by the time you reach the age of 30. And the lower the bone that you have at the start of your process, and we'll talk about that in a minute. So if your highest peak bone mass is at 30 and you didn't reach that peak bone mass due to dietary concerns or something else, you start at a lower level. So you have less bone to actually lose before you actually can cause fragility and problems with your bone. During adulthood, turnover is more moderate. Formation is slightly less than resorption. However, there is, overall a bone formation until we hit menopause in women. And it's also age related. So for men, once they hit the age of 50, they start to have a net bone loss. And for women, that net bone loss occurs after menopause. So this picture just really depicts the remodeling cycle on a small trabecula bone. So it's just to explain what's happening at the microscopic level, at the level of the bone. So we have mediators. So a micro crack, like I mentioned, you're sitting in your seat right now, and your bones naturally, everyone sitting there is forming micro cracks. They're completely normal. These micro cracks form. They release mediators that the blood vessel then brings in local factors to then enable cells called osteoclasts to then clean out the area of the micro crack, and they would clean out this area and then move along the micro crack and slowly, take away bone that's damaged or cracked in this area. Then osteoblasts, which are lining cells that then get remodeled into cells that now do bone formation, come in and repair that micro crack and repair the entire area. And in patients that are younger or people that do not have osteoporosis, the amount of osteoclast refilling and repair equals the amount of bone taking away by osteoblasts. just to show you on a depiction of, what this looks like, say at the level of a vertebra, the contrast between healthy and osteoporotic bone. So healthy bone certainly has, this is called trabecular bone. That's the stuff with the red holes in it. This is healthy trabecular bone. You can see that, the trabeculae are fairly robust. As you know, the strongest structure in architecture is a triangle. And, trabecular bone is fairly triangular. It has a lot of trabeculae. It's fairly robust and strong, where we can contrast it to osteoporotic bone, where now these trabeculae and spicules have become extremely thinned. There are holes that are formed. There are areas that no longer have that triangle shape, or, a shape that would give strength to this. And this leads to the potential for collapse of this vertebra, where the top of the bone here collapses on top of the bottom bone of this vertebra. And on a microscopic scale and more of an X-ray version, we're seeing the same thing. So this is a picture of healthy bone where the trabeculae are extremely robust. That you kind of have these, while they are round, it does form a very strong structure. And here on the other side, these trabeculae have become extremely thin, causing holes. And it doesn't take a lot of imagination to think that, there will be collapse of this, because it just isn't holding up the strength that it needs to. And this is only referring to the vertebra right now. So common sites of osteoporotic fracture include the spine, in particular the thoracic spine, so at the level of T10. The wrist is a very common site of osteoporotic fracture. And of course, the hip, especially at the level of the femur, which is right here. So that is the hip bone, that neck area before it joins the actual hip joint. So a femoral neck fracture, or a femoral neck fracture is not uncommon in osteoporosis. And these are the things that we really want to prevent in treating this disease. So again, an X-ray looking at vertebral fractures that have already formed. This patient has a wedge fracture, and you can see that this vertebra has collapsed in kind of like a wedge formation, and this one is kind of collapsed in the center, giving it a smaller height than, say, its adjacent vertebra. So what is the prevalence of osteoporosis? We think about other diseases as being extremely dangerous, right? And I'll get to that in a couple of slides. But we don't really think of osteoporosis as being life-threatening or dangerous in any way. So it's my job today to convince you that osteoporosis actually has a significant mortality associated with it. The prevalence of osteoporosis, and this is an older slide, so the prevalence is actually higher than this, but we have at least 44 million Americans who are at risk of osteoporosis. 55% of all people over the ages of 50 have osteoporosis. So that's more than half of patients that are 50 years or older. That's a pretty high statistic. 10 million people actually have osteoporosis, and 34 million more are estimated to have a low bone mass. 40 to 50% of women and about 20% of men who are over the age of 50 will experience an osteoporotic fracture in their lifetime. So that's half of women and at least 20% of men over the ages of 50 will actually break a bone due to a fragility fracture. And by fragility fracture, we're talking about, a slip and fall. You should be able to have a fall or slip on the ice, or, we're not talking about car accidents. We're not talking about falling down the stairs. We're talking about I walked across my driveway and I slipped and I fell and I broke my hip. Okay, your bones should be strong enough to withstand that type of trauma. So if you break a bone from a slip and fall, and it doesn't matter how quote unquote hard that fall was, it doesn't matter that, oh, it was a really bad fall, I slipped on the ice, my feet went up in the air and I fell really hard, doesn't matter. It's from a standing height. Your bone should be strong enough to not break under those circumstances. So if you have had a fracture from a standing height, you definitely should be screened for osteoporosis and consider talking to someone about treatment. The prevalence of osteoporosis is expected to continue to increase, obviously with the growth of the elderly population, and our need to screen and consider osteoporosis in our patients is very important. An estimated 1 in 2 women and 1 in 5 men over the age of 50 years will experience an osteoporosis-related fracture. So just to bring the statistic, perhaps a little bit more clearer. We think about uterine, ovarian cancer, breast cancer as being life-threatening. No one questions that, right? We go for our mammogram screenings, we go for our pap smears, we get screened for ovarian cancer as appropriate, and no one questions if our primary care doctor says, oh, you have to get these tests done, it's considered standard of care. But I would like to point out that a woman's risk of hip fracture is equal to the combined risk of breast, uterine, and ovarian cancer. So really, we should be thinking about osteoporosis as being a much more significant disease to screen for. Not that we should not be screening for breast, uterine, and ovarian cancer, but that osteoporosis is actually perhaps even more of a risk than some of these other conditions. A woman with a hip fracture has a 4-fold greater risk of getting a second one, and we know that the morbidity and mortality increases with the number of fragility fractures that you have, especially hip fractures. 24% of hip fracture patients that are aged 50 and over die in the year following their fracture, 24% of them. 1 in 5 of those who were ambulatory or walking around before their hip fracture will require long-term care afterward. They will not be able to get around. They are, oftentimes put in a nursing care facility, long-term, etc. So this is, a real change in their lifestyle and to their overall health. And at 6 months after a hip fracture, about 15% of hip fracture patients can walk across a room unaided, which means that 85% of patients who had a hip fracture at 6 months cannot walk across a room unaided. So again, osteoporosis is underdiagnosed and undertreated. I'm not going to belabor that point. I'm going to talk a little bit about men and osteoporosis because we think of osteoporosis as a disease that affects women, but this is not the case. It very much affects men, and we do need to consider our male patients and consider screening and make sure that they are screened for osteoporosis. And we recognize that men are underdiagnosed, osteoporosis is underrecognized, underreported, and inadequately researched with regards to males and osteoporosis. We don't have as much research available to us in men and osteoporosis. However, a lot of the paradigms that we use do apply to both men and women. So a little bit about men and osteoporosis. There are about 2 million American men that suffer from osteoporosis. And again, I think the stat is higher since this is an older slide. 3 million men are at risk, and about 1/3 of male hip fractures are related to osteoporosis. 1/3 of these men will not survive. They will not survive. 30% of men that suffer a hip fracture will not survive 1 year after their fracture. So, that's an incredible statistic to me. Okay, so I hope I have convinced you with regards to the importance of screening for osteoporosis and making sure that we diagnose osteoporosis and that we treat it appropriately. I'm going to move on with regards to some of the risk factors that put you at risk for osteoporosis. And some of the risk factors for osteoporosis include the following. First of all, personal age of fracture after the age of 50. So if you have broken a bone after the age of 50, that's something that has to be investigated. It's not normal to break bones. and we want to make sure that it's not due to bone fragility. If you have a current low bone mass, so if you have gone for a bone density scan and your bone density shows that, yes, you are osteopenic or osteoporotic, that's obviously a risk for fracture. A history of a fracture in a primary relative, so a mother or a father or a child or sibling that has had a hip fracture puts you at risk for the possibility of a hip fracture or other fractures. So you should be screened. Being female puts you at a higher risk. Being thin or having a small frame puts you at a higher risk. Advanced age, the older you are, the higher your likelihood of having osteoporosis. A family history of osteoporosis, as I mentioned. Estrogen deficiency. So this is why we talk about women that are postmenopausal. In general, any postmenopausal woman, once they have gone through menopause, should be screened for osteoporosis. If your primary care doctor has not screened you for osteoporosis and you have gone through menopause, you should ask for a bone density scan just for screening if that hasn't been done. Estrogen deficiency as a result of menopause or as a result of surgical intervention. So for example, if you have had an oophorectomy and had your ovaries removed earlier in life, so you are not producing estrogen, that puts you at a significant risk for osteoporosis at an earlier age, and so you should be screened. Amenorrhea, so for example, athletes that compete, particularly stringently, so people that run, Ironman races and things like that, we're talking about significant exercise, that are amenorrheic. They don't have their periods. They are in an estrogen deficient state. And while you might think of, I'm running an Ironman, I'm healthy, I do exercise, that is true, but your estrogen deficiency is really what's going to affect your bones. And so they should be screened for low bone density or osteoporosis. Anorexia nervosa or eating disorders is a big risk factor, especially, if it occurred in childhood, because you would not have made the um, optimal bone level that you should have at a younger age. So the less bone you start with, or the less mineralization of your bone that you start with, the less you have to lose. A low lifetime calcium intake. So if you're not somebody that really drank milk in childhood or ate cheese or yogurt or, other calcium containing dietary foods, that puts you at an increased risk. A low vitamin D is certainly a risk factor. Certain medications are risk factors. And the biggest one is oral corticosteroids. So someone with a history of asthma, for example, that has been on pill prednisone or pill glucocorticoids for, say, months at a time over the course of their life, that puts you at a very increased risk for osteoporosis, and you should definitely be screened. Anticonvulsants are another culprit. Proton pump inhibitors or medicines that are used to help with peptic ulcer disease are another medication that can increase your risk for osteoporosis. Presence of certain chronic medical conditions like rheumatoid arthritis, so inflammatory arthritides like RA, psoriatic arthritis do increase your risk for osteoporosis. Low testosterone levels in men. And usually the question that I ask my male patients is, do you have any difficulty with having a priapism or an erection, which may indicate a low testosterone level? And then if the answer is yes, then we would continue to test their testosterone levels. And that is a risk factor for osteoporosis. An inactive lifestyle where you haven't had much in the way of weight-bearing exercise certainly increases your risk. And one of the few things that being overweight or obese actually protects you against is osteoporosis. It is probably the only condition that our overweight patients actually get help from with regards to their weight. While I do not endorse being overweight. Usually our overweight patients do not suffer from osteoporosis, basically because of the burden that has been placed on their bones. And in general, they tend to have fairly strong bone health. Any cigarette smoking it puts you at risk for osteoporosis, whether it's current or in the past. Excessive use of alcohol, and this is usually 2 to 3 alcoholic beverages per day. And then ethnicity, being Caucasian or Asian, increases your risk above other ethnicities with regards to osteoporosis. So let's talk a little bit about bone mineral density testing. What is bone mineral density testing? What does it mean? Why do we do it? Who needs to be tested, etc. So I'll give you a couple of slides relating to that. So in clinical practice, bone mineral density remains the gold standard for diagnosis of osteoporosis. It is one of the best determinants of bone strength, and it does correlate with fracture risk. That said, I just have to give you the caveat that if you have fragility fractures and your bone mineral density test is not bad, it's in, say, the osteopenic range or maybe even normal, the fact that you're breaking bones is more important or more indicative of osteoporosis than the actual number on your bone mineral density test. So please, take that seriously. But in general, the test, the bone mineral density test, does correlate with bone strength. Bone mineral density predicts fracture as reliably as, for example, blood pressure predicts the possibility of stroke. So while, it doesn't necessarily mean that you're going to fracture, it is a predictive risk. So what is a bone density test? What does it look like? This is a picture of someone undergoing a DEXA scan. Basically, you lay on a bed. There is this arm that comes over. It has very little radiation. In fact, the radiation that you are exposed to during a bone density test is about the same as the radiation that you would be exposed to if you traveled from New York to California on a plane. So it is really a relatively low radiation test. And what is the T-score? What is that bone density result? So your bone density will spit out a number with regards to what your quote unquote T-score is. What is a T-score? So a T-score is basically a standard deviation below normal. So let's say, so this is a woman, and we are testing her against 30-year-old normal bone mineral density mass, healthy women who are of the same ethnicity or race. So she would be tested against a Caucasian 30-year-old female, and her T-score would be a standard deviation. If it's -1, it's 1 standard deviation below this normal healthy bone. If she's -2, she's 2 standard deviations below normal healthy female Caucasian bone. And if she's -2.5 is her T-score, then she's 2.5 standard deviations below a normal healthy Caucasian female. We arbitrarily define osteopenia as being a T-score between -1 and -2.4. It's actually -1.1 and -2.4. And we arbitrarily define osteoporosis as a standard deviation or a T-score of -2.5 and lower, okay? So -2.5 to -3, -4, etc. So who should we test? We should consider testing and doing a bone mineral density test in all postmenopausal women and men who are 50 years of age and older. We should consider in. It is not absolute necessary, but it should be a consideration. It is recommended for any postmenopausal woman who's over the age of 65. So if you are over the age of 65 and have not had a bone density test, you should definitely talk to your primary care about getting that done. And it should be done in younger women that have multiple osteoporotic risk factors, meaning Maybe they're on medications that might put them at a risk for osteoporosis, or anybody that's had a fragility fracture. So any male or female that's actually broken a bone from a fall with no, this isn't a car accident. This isn't I fell down the stairs. I'm talking about I slipped and fell and broke my wrist, or I slipped and fell and, broke my hip. They should be tested, and it doesn't matter what their age is or what their, anything else, what their risk factors are. They should be tested. Any men and women who have diseases or are using medications that can increase the risk of osteoporotic fractures, so PPIs, steroids, people who are smokers, people who have significant alcohol use should all be screened. Men over the age of 70 that have no risk factors. So in general, we say, men over the age of 50, if they have risk factors, but if you have no risk factors and otherwise are healthy and nothing else going on, no prior fractures, everything is good, over the age of 70, you should definitely have a bone density screening test. So who do we treat? In order to explain our current pharmacotherapy guidelines, I want to just tell you what the previous guidelines were. And please disregard this slide, okay? So let it go in your brain and let it go right out. It's really only to explain kind of what we used to do, but it no longer applies. So previously, we were testing anybody that had a bone mineral density T-score below -2 in the hip with no risk factors, and anybody with a T-score below -1.5 with one or more risk factors. So as you can imagine, we were testing and treating, actually not testing, we were treating patients a little bit too aggressively. These were patients that, were osteopenic, but we didn't really have any concrete evidence for what their actual risk for breaking a bone might be. And I'll get to that in the next slide. So, and of course, we would screen or test anybody or treat anybody that had a prior vertebral or hip fracture. Now, the WHO recommends appropriate intervention for men and women, and this still holds, okay? So this is true. Anyone that has a bone density of -2.5, meaning their bone density is in the osteoporotic range or less, definitely warrants treatment, and that still holds true. And if your bone density is -2.5 or lower or more negative, you should definitely undergo treatment for osteoporosis. Currently, we use what's called the fracture risk assessment. And this is an algorithm developed by the WHO, which basically calculates what is your absolute fracture risk depending upon your T-score, and what is the risk that in the next 10 years you're going to break a bone. It is only, and I'm going to say this 2 times because it's so important, it is only applicable for patients that have osteopenia. If you have osteoporosis, meaning your T-score is -2.5 or worse, you go on treatment, okay? You do not use this algorithm to decide should you go on medicine or not. You need to go on treatment. This is sort of an improvement instead of, like I said in the previous slide, where we were just arbitrarily choosing patients that had a T-score of -2 or a T-score of -1.5 with risk factors and automatically putting them on medicine. We're now looking to see, okay, you're osteopenic. What is your actual risk factor for developing a fracture in the next 10 years? And it estimates, what is the likelihood that you'll break a bone either in the hip or any other bone in the course of the next 10 years. And this is what the fracture risk assessment looks like. I'm not going to go into it. It's more for your doctor to use as a tool to calculate, but I just want to show you what it is. We enter all your information. We enter whether or not you have, any alcohol use, any risk for secondary osteoporosis, meaning do you have hyperparathyroid disease? Do you have low vitamin D, et cetera, et cetera? Do you have rheumatoid arthritis? Have you been on steroids? Are you currently a smoker? Do you have a parent with a risk of, or a parent that's had a hip fracture? Have you personally had a fracture in the past, et cetera? And then we enter all that information and it spits out a score. So the risk factors in the fracture risk assessment model that are considered to be truly viable with regards to concerns with regards to whether or not you might be at risk for osteoporosis or for fracture include, what is your age? So the older you are, with whatever T-score you have, the higher your risk for fracture. Your gender, being female, certainly puts you at a higher risk. If you've had a prior fracture, so any kind of fragility fracture, vertebral fracture, you're automatically osteoporotic or at a higher risk. If you've had a low bone mineral density at the level of the hip or the femoral neck, if you have a low body mass index, so you're very thin, small frame, small person, that puts you at a higher risk. If you've been on oral steroids, so pill glucocorticoids, if you have a history of inflammatory arthritis, so rheumatoid arthritis, psoriatic arthritis, I would include in here, that puts you at a higher risk. If you have secondary osteoporosis, meaning you have hyperparathyroidism, or you have low vitamin D, or you have other conditions that would cause you to have a low bone density, that would certainly cause an increased risk for osteoporosis. A parental history of a hip fracture, so mom or dad that had a hip fracture. If you are currently a smoker or been a significant smoker in the past, and if you have had alcohol intake that's significant, currently 3 or more drinks per day. Okay, so I'm going to skip this slide because it just reiterates what I said. So just to summarize, clear need to treat, or based on the most recent guidelines, we need to treat postmenopausal women or men over 50 with a T-score of -2.5 or lower. Okay, so these are people that have osteoporosis. There's no controversy. You have a T-score of -2.5, you have osteoporosis, you need to be treated. Or postmenopausal women or men over 50 that have had a hip or spine fracture or another fragility fracture, and it doesn't count toes or fingers. Okay, so we're talking about wrist, spine, hip, ankle, etc. So excluding toes and fingers. If you have had an actual fracture from a fall, clear need to treat. Doesn't matter what your T-score is, you need to go on therapy. Now, using the fracture risk assessment or the FRAX calculation, it's osteopenic patients that have a 10-year probability of hip fracture that is more than 3%. So if your calculation comes out to, yes, in the next 10 years, you have a likelihood of breaking a hip that is more than 3%, you should be on therapy because the risk of fracture is greater than any risk from the medication. And patients that have a risk of what's called a major osteoporosis-related fracture, which is actually a misnomer. It's not a major osteoporotic fracture. It just means a fracture anywhere else. So we're talking about a fracture in the wrist, a fracture in, the ankle, a fracture in the spine. That is more than 20%, then yes, you should be treated. So when you get your bone density report, if you do get the full report, they usually give you the FRAX calculation as part of the report. And it should tell you what is your hip fracture, FRAX score, and what is your MOF or major osteoporosis related fracture score. And as long as it's less than 3%, less than 20%, and you are osteopenic, you probably can just continue calcium and vitamin D. But if it's more than 3% or more than 20%, then you should be on therapy for osteoporosis. Again, the fracture risk calculation is for untreated patients. It does not count, or it is not used for people who have already been treated for osteoporosis. So we do not use this on patients that are currently on therapy. It's not applicable for that. They're already on treatment, and then the doctor will make decisions, based on that. So it's really for patients that are untreated and very, very specifically in the osteopenic range, meaning your bone density score, your T-score is between -1 and minus 1 point, and minus 2.4, 2.4. Does not apply to those already taking medication or patients that are diagnosed with osteoporosis. Okay, so I'm just going to show you what a standard bone density looks like the full scan. So this is a bone density looking at the vertebra. So when you lay in the bone density scan, the DEXA scanner, it looks at your spine. And this person's bone density T-score across L1 and L4 was actually 2.4. So it was not a negative number. It was actually slightly high. And their bone density score across the femoral neck, which is in this area right here, is minus 2.4. So they are in the osteopenic range. So now what do we do based on what I just told you? Because they're osteopenic. And remember, we have to take the lowest T-score. We take the worst calculation to make our therapeutic and diagnostic decisions, okay? So the fact that the spine T-score was positive or good isn't the T-score that we're looking at. We're looking at the T-score of the femoral neck, which is the lowest T-score, which was minus 2.4, okay? So they are osteopenic, and that's the score that we're going to be working with. We enter it into our fracture risk assessment tool, and it spits out, once you do the calculation, it spits out that the risk for a major osteoporotic fracture is 24. And what did I say the cutoff was? 20, right? So this patient is 24, so that's above the 20% risk. And their risk for hip fracture is 5.8. And what did I say the cutoff was? 3%. So their risk is significantly higher than the cutoff. So this person, even though they're osteopenic and even though their spine T-score is actually not bad, they need to go on therapy for their osteoporosis. Okay, let's talk a little bit about osteoporosis treatment. And I know we're running out of time, so I'll keep it to 5 minutes or less. So basically, the treatment goals and strategies are as follows. There are a number of non-pharmacologic treatments, meaning vitamin supplementation, calcium, and the recommendations currently are that you take 1,000 milligrams a day of calcium, and it should be divided into 2 doses. So 500 milligrams twice a day. If you take more than 500 milligrams at a time, you're just going to excrete it, through feces. So really, it should be 500 milligrams twice a day. Vitamin D, anywhere from 1,000 to 2,000 units once a day, and that can be taken all at one time. And then the pharmacologic treatments that we have at our disposal fall into 2 categories. One is an anti-resorptive category, and the anti-resorptive category is basically designed to maintain your bone density. This is for patients who have a bone density that's low, but maybe they're younger. For example, they're 65. Their bone density is minus 2.7. So yes, they're osteoporotic, but they're young, right? They're 65. We want to maintain their bone density. We don't necessarily want to give them a medication that may have other side effects or more, a stronger medication to build bone, considering that, overall the risk for fracture is not as low as it could be. It's not bad, and we can put them on a medicine that's just going to maintain the current bone density, and the goal is to prevent further bone loss. And these include medicines like alendronate, which is called Fosamax, Rezidronate, which is called Actonil, Ibandronate, Boniva, zoledronic acid, which is reclassed, and denosumab, which is called Prolia. The anabolic agents, these are medications that are actually designed to build bone. These are for patients that have a bone density score of -3, or that have had fragility fractures, meaning they've already broken a bone and proven that they have severe osteoporosis, irrespective of what their actual bone density score is. And so these are medicines like Forteo, Avinity, etc. The other category on the bottom, I would disregard. Hormone therapy, estrogen. If you have to be on hormone therapy because of menopause symptoms, that's great, but we don't use hormone therapy to treat osteoporosis by itself. but it does help with osteoporosis if you have to be on it for other reasons. Raloxifene and calcitonin are not very robust therapies, and these are no longer medications that I would recommend in my practice to treat my patients with osteoporosis. I have much better medicines to use. Okay, so I'm going to talk in 2 minutes about some of the very concerning side effects that people worry about when it comes to treatments for osteoporosis. And one of the biggest ones is osteonecrosis of the jaw, or bisphosphonate-associated osteonecrosis. So osteonecrosis of the jaw is basically a condition where, and it's very specific, it's in the setting of having implants put in or teeth pulled out. So if you are not having teeth pulled out or implants put in, your risk for this complication is no greater than somebody who is not on medicine for osteoporosis, okay? And that is a key point. But what is it? It's where the area of the gum at the site of where an implant was put in or a tooth pulled out doesn't heal. It exposes the underlying bone. It has to be treated very aggressively with either antibiotics and, in very, very, very severe circumstances, replacement of the jawbone. So yes, I can say that this is devastating if it's severe and occurs, but here's the caveat. It is extremely, extremely rare. And let's look at how rare, okay? Your risk of anaphylaxis, so going into anaphylactic shock from getting penicillin, is 32 in 100,000 people per year, okay? Your risk from dying in a car accident is 11 per 100,000 people per year. Your risk for being killed, murdered, is 6 in 100,000 people per year. Your risk for osteonecrosis of the jaw is 0.7 per 100,000 people per year. And your risk for being killed in a lightning strike is 0.6. So basically, I would say your risk for osteonecrosis of the jaw for this complication, only in the setting of getting teeth pulled out or implants put in, is about the same as getting hit and killed by lightning. Now, what is your risk for a fragility fracture? It's about 2,668 in 100,000 per year. So basically this bar graph goes across my office, out the door of my office, and across the street, okay? In terms of the actual size of the bar graph relative to what we're looking at. Your risk for hip fracture is 387. So this only goes to the door of my office. But as you can imagine, your risk for breaking a bone is so much greater than this concern that everyone seems to glom onto and worry about. That is extremely rare, extremely unlikely, and only in the setting of having implants or teeth pulled out. Okay, I'm going to skip this. There is one other potential side effect from the bisphosphonate therapy if you've been on it for many, many years, and this only pertains to medicines like ibandronate, risedronate, and alendronate. So we're talking about Fosamax, Actonel, and Boniva. After being on it for 12, 14, 20 years, patients were developing unusual fractures of the thigh bone because the medicine was so good that it would strengthen the bones and actually cause them to be more brittle. So for this reason, patients that are on that class of medication, after about 6 years, we talk about going on a drug holiday, meaning you've been on it for 6 years, we've been following your bone density, you've been doing well, your bone density is stable, we're going to stop it, and we're just going to follow your bone density over time. Whereas previously, we kept patients on these medicines lifelong, and that's where this complication came up. We're no longer doing that. We no longer keep patients on the bisphosphonates forever and ever. And you know, this is no longer a complication that should happen. Okay, so in summary, osteoporosis is a common condition associated with substantial health and economic impact. It is silent, meaning it doesn't hurt until you break a bone. So when you go to your doctor and you say, oh, I have osteoporosis in my right hip, is that why my right hip hurts? No, your right hip hurts because of something else. It has nothing to do with your osteoporosis unless you broke a bone, okay? It is often underrecognized, it is undertreated. The improvement in bone health and reduction in risk of osteoporosis-associated fractures is possible through not only good health practices like exercise, a balanced diet rich in calcium and vitamin D, healthy lifestyle with no smoking or excessive alcohol use, and of course, appropriate screening and evaluation to determine the need for treatment. So with that, I'm going to end my slides and I'll take any questions if anyone has any.
I see we have an attendee asking the question, why do some people die after a year of a hip fracture?
Yeah, so usually it's due to the comorbidities of being immobile, being bedbound, especially if you're older. It increases risk for infections, pneumonia, um, bed ulcers, a number of comorbidities that unfortunately the statistic says that, you know, the likelihood of death is fairly high.
We have a question from Teresa. You can ask your question, Teresa.
Hi, I took 2 shots of Boniva and I went to get a tooth pulled and they would not give me an implant, which I was happy about because I was on Prolia. So I decided to opt out of it. And my gynecologist has my bone density tested every year. I don't know my score. Should I ask her for the score? She keeps on saying to me that she wants me to take the Prolia. I'm very anti-drug and I am extremely active. I do some sort of strenuous exercise every day. I am 75. I don't drink. I did drink a bit at one time. I don't have any history of it. Am I playing? She thinks I'm playing with fire, not taking the shot, but I'm
So
so against it.
I would trust your doctor. I mean, there's a reason that she feels you should be on it. And I don't have any information. I don't know what your bone density is. I don't know the information, but you know, your doctor feels that your risks of developing a fracture is higher than the risk of the medication. So if she feels strongly that you should be on therapy, I would take her advice. Now, that said, you alluded to something else. You said that you went for tooth implants, didn't wind up getting them.
Right.
You know, if there's an issue where you are planning tooth implants.
No, I'm not. I was lucky. I actually lucked out because I really didn't want the tooth implant.
Okay, but for anybody that's in this audience, let's say you're on a medicine for osteoporosis and you develop a problem with your tooth and it winds up being that you have to have a tooth pulled and implants put in. You go off your medication for 3 months, and then your orthodontist or whomever can go on with, you know, the procedures that they need to do. So being on medicine for osteoporosis does not prevent the ability for you to then get whatever therapy you need for your teeth. You know, it's just recommended that you go on a 3-month hiatus.
Okay. Thank you.
You're welcome.
We have a question in the chat from Brian. Is a non-traumatic sternal fracture considered a fragility fracture?
I can't imagine how a sternal fracture would happen if it was non-traumatic. It's just in such a location that, did you, like, so you didn't hit the steering wheel or, you know, that's just extremely unusual. So I'm not sure.
You could ask your question, Brian.
I was pushing hard on something and installing something that required pushing, and
Okay.
I sustained the fracture in that manner.
Okay, so you were pushing on an object forcibly,
Yes.
and so look, that's a tough one because rib fractures technically don't count, finger fractures don't count, and toe fractures don't count. A sternal fracture, one could argue that that's kind of like a rib fracture. What I would say to you is get a bone density, you know, have it screened. it's enough of a question to say, maybe we should
Oh,
check.
yeah, thank you.
Mhm.
We have, let's see, a question from Wendy. My osteoporosis doctor retired, and my new doctor said she could not compare my new bone density test against his since they were different machines. His
Yes.
machine was inaccessible. So after 12 monthly sessions of Invinity and then seeing a new doctor, I had no way to know if it worked. Does this make sense?
Yes. So unfortunately, there is a room for error with regards to how the test is done based on the technician that does it and the actual machine that is used. So we always recommend to our patients that they go back to the same machine that they went to last time for direct comparison purposes. That said, your doctor can certainly make some decisions based on a de novo bone density on a new machine. I mean, they can certainly decide, look, I can't directly compare the two bone densities, but I can tell you that your bone density on this machine looks blah, blah, blah. And the one that you had 2 years ago looked blah, blah, blah. And overall, it looks like this one is better, but I can't officially tell you that it's better. But you know what I mean? We can extrapolate from that. But you're right. Your doctor is correct in saying that they cannot officially um, compare different sites, different machines, different technologists. And across the board for anybody that's in the audience, you know, if you're getting a bone density, try to go back to the same place that you had the last one done for comparison purposes so that they can compare your previous depth.
We have a question from Lori. Are the risks related to teeth pulling or implants are all the same at the same time of medication? What if months after the teeth were pulled or the implants done?
Yeah, so basically the recommendation is once the area of, so say you had a tooth pulled and an implant put in, right? Once the implant area, the gum has healed, you can go right back on your osteoporosis medicine, or you can start osteoporosis medicine. As long as it's healed up, there should be no risk.
Can you hear me now?
Perfectly.
Okay. I was just questioning the shots that are available. And it seems that there is, I don't know, it seemed like such a high risk of complications. And it also seemed that when you go on these shots, you can't get off of them. So, I mean, and also the shots versus pills. Those are my questions. Thank you.
So let me try and clarify the different medicines that we use to treat osteoporosis. So the shot that you're probably talking about is Prolia, or denosumab is the generic name. And that's a once every 6-month injection, so it's twice a year. The pill medications are the bisphosphonates, which include medicines like Fosamax, Actonel, so alendronate, risedronate, and abandronate, otherwise known as Boniva. So in terms of side effects, I'll be honest with you, Audrey, the side effects are pretty much the same for both types of medication, with one exception, and that is that the pill medications can cause irritation to the esophagus, and heartburn, which is why we recommend when you take them, you have to fast for an hour after taking it. You can only drink water after taking it. You have to wait an hour before you can take any other medicines or pills or food. So I disagree with the concern that the injection medication, if you're talking about denosumab or Prolia, as being worse than, say, the oral medicine. They all have very similar side effects. And the side effect profile is very similar. If you're talking about the anabolic medicines, so these are the medications that cause new bone growth. And I don't think I talked about them at any length. But these are medicines for people with severe osteoporosis, and they include medicines like teriparatide, which is known as Forteo, which is a daily injection given for 2 years, self-injection that you give yourself every day for 2 years, or rososozumab, which is known as Evinity, which is a once monthly injection that's given by your doctor in the office once a month for 1 year. With the exception of those medicines, which may have some additional side effects, but really not significantly different, there really isn't a difference between Prolia and the bisphosphonates.
Thank you. Thank you very much. It looks like we've had our questions all answered there. I'd like to thank everyone for Zooming in, all of the participating libraries along our East End, Stony Brook University Hospital for being able to present these talks on a monthly basis. And as Karen mentioned earlier, next month's talk will be on breast cancer because October is Cancer Month. And I'd like to thank Dr. Roppelt for this wonderful talk with this great PowerPoint, and for going over a little bit of the basics of what involved with the osteoporosis, and having my mother's dealing with that actually for over 20 years. But she's building bone density. And once again, I hope everybody has a wonderful day, week ahead, and we'll see you on the next talk.
All right. Well, thank you everyone for inviting me, and I really appreciate the opportunity to come and speak to you all. Have a great day.
Thank you. You too. Bye-bye.